Welcome everybody to Modern Management of the Stiff and Painful Shoulder. My name is Eric Chaconas, and along with me is Mark Shepard. We both work for Bellin College. We have a Doctor of Science degree in physical therapy as well as an orthopedic manual therapy fellowship. We are going to really focus on this model of shoulder care where we're looking at the stiff and painful shoulder and considering particularly that level of irritability, levels of high irritability, and how that can be such a challenging, really condition to present in our clinics. And I think Mark and I talking through this kind of thought, that's something that both of us have developed and changed a lot in the way in which we've managed this condition, and really has changed a lot from what we've learned in the literature and some of the new emerging themes that have come from the literature that have really advanced the way in which clinicians can approach this condition. So there are the objectives there for you. We are going to look at these different models of different levels of irritability, current best evidence, and some strategies, and really try to give you some take-home little pearls and ideas that you can use in the clinic to help these patients. The staged approach for rehabilitation of classification of shoulder disorders, the McClure 2016 paper, that really is a wonderful breadth of information when we look at this condition and consider levels of irritability and a physical impairment. So getting outside of just the diagnosis, it's so much more than just a diagnosis. Considering those other variables really is what's going to dictate treatment, right? There's no one-size-fits-all treatment per diagnosis. And then the clinical practice guidelines, the shoulder pain and mobility adhesive capsulitis clinical practice guidelines from 2013 are another really wonderful resource of information when we look at both the classification of these conditions and as far as the exam goes, as well as current best evidence related to treatment. So I think one thing that both of those resources don't give us, and where this gap still lies, and what Mark and I really hope to address today, is they kind of look at this high irritability case as activity modification, modalities, manual techniques, gentle, well-tolerated manual techniques, and really that's kind of it. There's this huge gap in how do we manage this high irritability, stiff and painful shoulder. As the level of irritability gets reduced and we look at moderate and low levels, there's a lot more that can be done. And I think those papers do a really nice job of highlighting that, but there is a gap in this kind of high irritability case, and that's what we want to sort of address today a bit. So we are primarily talking about both adhesive capsulitis and post-operative stiffness. Adhesive capsulitis has actually higher than you would think prevalence in our society. So this is a condition that certainly does come into our clinics quite frequently. You can see about a 2 to 5.3% prevalence across the population. But when you look at those with diabetes, the prevalence rate's actually closer to 20%. So with these risk factors like diabetes, thyroid disease, they really do increase the prevalence in those populations of individuals. But commonly we're looking at female more than male, kind of that middle age range of 40 to 65. Males do get insidious onset adhesive capsulitis, but with much lower frequency. The interesting thing though, when you look at the literature, males tend to do worse. Their outcome tends to be worse. They don't tend to have as much success, especially with conservative measures like seeing a physical therapist. So we're all familiar with this process where the individual is going to go through this early synovitis, and the condition could look like any other shoulder pain condition, right? It can mimic so many others, but then develop this gradual loss of motion, which really is hallmark to the condition. And so that's when we want to really try and intervene early on, reduce that motion loss, and get them back to normal mobility as quickly as possible. It is self-limiting. Over time, it will go away, but oftentimes that's going to take multiple years, and you'd like to try to intervene earlier through the course of care. The diagnosis, when we look across the literature, is really multi-direction motion loss. The capsular pattern has not been really found in the literature that we see some specific direction more than another direction. The bottom line is multiple directions of motion loss. Accessory mobility is certainly going to be reduced as well. And then we oftentimes, depending on the level of irritability, we'll see different levels of pain with the motion loss. Post-operative stiffness is kind of a different topic, different condition in a lot of ways, but at the same time does present very similar and can oftentimes be treated very similar. So this is the most common adverse event after a rotator cuff repair. After many different surgical procedures, when the patient's immobilized through controlled trauma or even just a shoulder injury, we will oftentimes see a reduction in mobility. And so that can happen anywhere from 1% to about 11% when you look at the post-operative population. And we really don't have good consensus on the diagnostic criteria for post-operative stiffness. The bottom line is they have significant motion loss. Usually it's in multiple directions after an injury or surgical procedure, whether it's restricted to 90 degrees or 120 degrees of elevation, to me, doesn't really matter. The bottom line is they have had an adverse event with a reduction in mobility, and we will need to see those patients and try to help them gain that mobility back. So these are the 3 levels of irritability as described in both the STAR irritability model by McClure, as well as that adhesive capsulitis clinical practice guideline. And it's very easy to classify a patient into high, moderate, or low levels of irritability. Obviously, numeric pain rating that the patient reports is a key variable. If they report very high levels of pain, if that pain is consistent and it's always there, even at rest, no matter what they do, it doesn't really go down, it doesn't really get reduced. It is very easy to be aggravated, doesn't take a lot of noxious stimuli to aggravate their pain. Well, that's probably high level of shoulder irritability. Moderate would be, progression down from that, where it's a lower level of pain reported on the numeric pain rating scale, but they probably have more intermittent resting pain. It's not that constant resting pain, and they don't have as much functional disability. So they're doing a little better, obviously, than the patient with high irritability. When you push them, you got to kind of push them into that end range to elicit those symptoms. So it doesn't take, it takes a little more of a noxious stimuli to reproduce their symptoms and give them pain. And then obviously the low level of irritability would be when we're getting close to a good outcome here at this point, because they have very low levels of pain reported, not a lot of resting pain at all, not a lot of disability. It takes a lot to flare them up, right? They're doing pretty good. So that'll be the framework that we'll kind of look at when we consider interventions as we move forward here. We kind of have to start with some of the psychosocial elements to our biopsychosocial model when we approach these patients. And so looking at understanding patient expectations is absolutely critical. We know that if the patient has a positive expectation that they will get better, they're probably going to do really well. So as clinicians, we always want to do everything we can to leverage patient expectations, to improve patient expectations through our therapeutic alliance and communication skills. But it's not a set. I think it's really important to look at expectations as it's not a set thing, right? These are very fluid, very moldable concepts. The patient doesn't come in with one specific expectation. I don't think I'm going to get better. I think I need therapeutic ultrasound. That's the only thing that's going to help me, right? That can actually change and evolve through the conversation that we have for them. And I think that's a really important thing to always consider. Early reduction in symptoms is key in my opinion. And Mark, I'd be eager to hear your thoughts on this. When we get an early reduction in symptoms early on in the course of care, to me, that builds proof. The patient sees it. Oh, they can help me. This is beneficial. I am gonna see some changes here. And that gives them confidence in the clinician. This clinician can help me. You build trust, leverage that expectation. So anything we can do to improve within session change, especially early on, whether that's with manual therapy or any other intervention, to me, that's a huge winner.
Yeah, I think that's a really good point. And in kind of our program's training, with this idea behind asterisk signs, which is common language in a signs and symptoms model, of finding something that reproduces their symptoms. And typically we really like to look at function because that's what we're about. And so if you have someone who says that I have trouble reaching up to the cabinet, into shoulder flexion or even scaption, there's your window of saying that's, maybe it's my most painful position for the patient. This is what bothers me the most. I know what I need to focus on in order to try to create some buy-in that I can do something or help them change those symptoms so that they can say, you know, I'm at the right place because I know that they're thinking of my chief complaint, and two, they're really working to try to change that in a way that helps me be empowered, and then again builds trust. And I don't think it's all about manual therapy trying to fix the patient. You know, like you said, it's so important to educate that patient, to empower them with exercise so that it provides confidence that they're seeing the right person. This person knows what they're talking about, and that they're listening to me, and then that builds the trust, and then that can mold the expectation throughout, as you said, that fluid kind of you know, change in beliefs that can happen at moment's notice between sessions and within sessions. So really, when we look at Chad Cook's work, you know, on different body parts, we see that within session change can be a big, you know, buy-in factor for between session changes. So I'm going to kind of go into here, you know, what happens when our patients are so irritable, meaning their symptoms come on very quickly and they stay around for a long period of time. You know, where do we go with those patients? And you might hear people say these are the folks that are almost too hot to handle, right? And I think if there's a great paper out there that was published, you look at this one by Eric Sawyer and colleagues that was published in 2018 in the Journal of Orthopedic Sports Physical Therapy. And what I loved about this is it kind of took something that I think a lot of people know about. Like, we hear about graded motor imagery, we hear about pain neuroscience education, but you know, how do we actually apply it in clinic with patients that we are working with day in and day out? And this paper really describes it very well. And so what I'd like to do now is kind of go through some of the hallmark aspects of graded motor imagery that you can utilize in patients who are very irritable, who come in with shoulder complaints. So when we look at graded motor imagery, we're going to be looking at a very systematic approach. And what most people get wrong when they utilize graded motor imagery is that they focus primarily on the mirror. The mirror therapy aspect of graded motor imagery is probably the most sexy of the process, because it's what most people learn in PT school, or what you might see in the research as being a hallmark part of that. And quite honestly, it's pretty fun to do and can blow your patients' minds at times. But when you look at graded motor imagery, when you look at what Mosley and Butler describe in a lot of their early work on this, is that you have to start at the beginning. If you skip steps here, from a neurologic and neuroplasticity standpoint, you can actually cause the patient's pain to increase, or you're not going to allow for that neuroplastic kind of structure to form in a way that is most beneficial. So if there's one take home when it comes to graded motor imagery, you need to start at the first step and work your way through the process and prove to yourself that that patient is ready to go to the next step. It's almost like return to sport or return to function after having surgery. You can't just load the patient with a lot of weight before they meet certain metrics to get to that next step. And again, it's not always time-based, it's basically performance-based. So where I really feel like it's important to understand this process is that you have to lay the groundwork with doing some good pain education. You have to then start moving into this laterality training, or left-right discrimination, working into tactile discrimination, towards motor imagery where you're imagining movements, and then finally that mirror therapy. So I'll go into each of these components a little bit more and kind of relate it to what you may see with someone coming in with a stiff and irritable shoulder. So first, as I mentioned, you know, we need to think about how we're educating patients about pain. And this paper here by Adrian Lowe and colleagues looking at the clinical application of teaching those in pain is really a hallmark paper, I think, on establishing kind of the down and dirty when it comes at doing this. And what you see here on the right-hand side is a figure from that paper that looks at probably the metaphor that resonates most with patients. And it's this idea that you come in and before you've had your shoulder pain, you had lots of room for activities, whether it be painting your walls or reaching up multiple times to put things up into the cabinet, exercise. And then now, because your shoulder and your shoulder region has become more sensitized, you have a little bit of room. So that's why your shoulder is becoming so sensitive with so little activity. And if we're thinking about a patient who comes in with adhesive capsulitis, this is really one of the nice things to show, is because you can actually see, all right, that makes sense. Because a lot of people say, why, I'm not even moving my shoulder, why is it so sensitive? Or even at rest, why is it so sensitive? So teaching about how the nervous system becomes sensitized to protect that area because it's in a healing process and is a natural thing. Just because it's hurting doesn't mean that there's harm or damage occurring at that shoulder once we've cleared all red flags in our evaluative process. And so what I think is helpful clinically is having either a dry erase board. I think that's probably one of the best tools that we can have as therapists, is to have one around, whether it's a small one you carry with you or you have one up in your treatment room or your clinic somewhere, but getting up there and drawing and explaining this. Eric mentioned earlier that the importance behind setting expectations. And so I think it's really important to kind of set the expectations for what is going to happen along with this graded motor imagery approach. Not only do we need to talk about why they're in pain and why their pain may be so irritable, but we also need to set the framework for what's going to happen with graded motor imagery. Because let's face it, it's not, kind of the picture of what people think physical therapy is. Nobody's really thinking about, is that a left or right shoulder? Oh, I'm moving my shoulder around in a mirror. That seems kind of weird and a little voodoo-y to me. And so a lot of patients may be off-put by that. So taking the time at the very start of working with the patient to lay out the groundwork, to lay out, this is where I'm going to start, this is where we're going. They know that you're not just grasping these concepts from, wherever you may be getting them from. It's very planned, and it's very important that you lay that out. And also letting them know that it's going to take some persistence, it's going to take some time, and it's going to take some effort. And so really trying to plan that expectation out in front is really important, because what we'll see when we're doing graded motor imagery with a lot of individuals is that the longer the symptoms and the more sensitive those symptoms are, the longer it may take to work through the graded motor imagery process. And so I'm very upfront with the patients about that, to let them know that it's going to take time and a lot of work. A lot of these processes with graded motor imagery and understanding the sensitive nervous system takes a little bit of time to change. But the good news is it can change. And with this, you are very much control of damping down that nervous system so that you can start to move and actually make some of those gains. So really, not only are you setting the groundwork for a foundation on good pain neuroscience so that they know you're doing what you're doing and why they're feeling the way they're feeling, you have to make sure that you are setting forward the plan and the prognosis for what you expect to see to frame those expectations. So let's talk about laterality training. This is something that I think I really had to dig into to get more understanding about, because it's not just about, doing left or right discrimination and moving on. There's a lot of different resources that you can utilize. I think my preference is actually using the actual app that the NOI group puts out, called Recognize. So you can see the name for the actual app up in the left-hand corner there. And I think Orientate is another one that you could use that, again, looks at left, right. But I really like using NOI groups, because it's just a little easier for me to kind of follow and the patient to follow as well. And so basically, when you're doing laterality training, you're showing, or they're being shown, pictures of the sensitized region. So in this case, the shoulder. And it's going to show a picture of a shoulder in a various position. So you may see the shoulder in flexion. It may be going across body. It may just be at rest, typically with a shirt off. And the patient is going to decide whether it's a left or right shoulder. The tricky thing here is that the app will actually move the shoulder into a different position. And then the patient is supposed to be very quickly deciding on whether that's a left or right shoulder. The key piece here, and what you have to tell your patient, is that they need to do this as quickly as possible. What you don't want them is to focus on it for too long, because actually that takes more brain power and more of that neurotag. So if they're super sensitive, it can actually flare their pain up a little bit. So the quicker they can do this, it has to almost be unconscious. So I tell them, don't worry about right or wrong. Just do it as quick as you can. The nice thing about the application is that you can actually set the speed at which the images change. So typically, depending on how much they struggle with this, you may increase the duration that they see an image. But I typically try to not go over 5 seconds, because again, I want this to be a little bit more rapid in pace, just for that neuroplastic component. The application also allows for some contextual factors. So you can actually have the shoulder showing pictures of different types of activities, versus just showing the shoulder, with the skin exposed type thing. So let's say we have a patient who's having difficulty reaching behind their back, or they're afraid of someone touching their shoulder. There's actually pictures with those types of aggravating factors that can start to increase the vigor, if you will, of that laterality training. So the nice thing about using an app is that the patient can take this home and they can work on it. Typically what you're looking for normative data on laterality training is you want to see roughly less than 2 seconds per image, and you want to see greater than 80% accuracy on this. If they aren't meeting that threshold there, then typically they need to continue working on it. And again, from a neuroplastic standpoint, this needs reps, and it needs consistency, and it needs practice. So it's important not to just do the 3 sets of 10 for this thing. Look at the Sawyer paper if you're able to and see how they dosed it, but you're going to want to be doing this often, typically 1 hour to 2 hours a day, split up over that day. So you really have to get that buy-in from the patient and show that this is something that's really helpful. The app, because it's nice and has those metrics there of seeing how long it takes you, gives them a little bit more data to work from. If they can't get the app for whatever reason, there's flashcards that you can order. And then also don't think about the power that can come from a magazine and the low tech versus high tech type of resource here. So using a magazine, opening a page and circling left and right shoulders also can start to stimulate those neuropathways. So moving on to tactile discrimination, in the Sawyer paper on the right-hand side here, you can see figure 4, where they actually created 5 different spots around the painful shoulder. And basically what they did is they took a picture of this. They had the patient put their affected shoulder behind the mirror and their non-affected shoulder in front of the mirror. And they started touching these areas. They went and touched number 1, number 4, number 3, number 2. And what they ended up doing is asking the patient, what side, which part am I touching on your shoulder? And again, they're doing it to the symptomatic side behind the mirror as they're looking in the mirror for them to decide on where that is. And again, this is the next kind of step in vigor to try to sharpen those brain maps on that sensitive shoulder. You won't be surprised if the patient is very sensitive that this can actually provoke their symptoms a little bit, believe it or not. So again, kind of taking it step by step. You can even do 2-point discrimination, which is what they did in the Sawyer paper. And here, this Catley figure is really nice to see, because it kind of shows the 2-point discrimination normative data in individuals that they looked at in these 28 healthy subjects. And in the Sawyer paper, they ended up doing 2-point discrimination kind of exercises here. And typically in the shoulder, I think you're going to be looking at 40 millimeters as kind of your normative data there. And again, finally, looking at mirror therapy for the shoulder. And I should say, before you get to this, you have your motor imagery that you're going to be doing before then. So you could take actual pictures of these movements and actually have them think about moving, which is something you want to do prepping to the mirror therapy. And the interesting thing about the explicit motor imagery, so again, thinking about movement, is that you shouldn't just have the patient think about the visualization of them moving. You actually have to have them think through what it feels like to move. There's a big difference between thinking about watching yourself move versus actually, how does my shoulder feel if I'm reaching up in front of me, if I'm reaching across my body, if I'm reaching back behind me. You have to think about the context. How does the air feel around my shoulder as I'm moving it? What is my shoulder blade doing? How does my neck feel? Being very explicit with that, and the more detail you can provide around the actual feeling of movement will start to stimulate those neural pathways. And again, you may start very simplistic and start to work more complicated as the patient is able to start doing this more and more. And that builds into this mirror therapy, where again, we have the symptomatic shoulder behind the mirror and the non-painful shoulder doing the movement. And again, you start to work towards just doing the non-symptomatic shoulder first in the mirror, and then you can actually have them, as they're moving their non-symptomatic side, also moving their symptomatic side behind the mirror as a next step. So there's different things that you can do to progress this. And Adrian Lowe and colleagues in 2017 found that there were some nice immediate changes in their range of motion and pain levels. Although they didn't meet the minimal clinical important difference or detectable change there, they're starting to show some progress there, and the Sawyer paper shows how that can help. And when we look at graded motor imagery, the prognosis is really, it depends on the patient. But in the Sawyer paper, I believe they did this for 6 weeks. So they spent graded motor imagery time for 6 weeks. So even as a therapist, I find myself having to kind of really be persistent and consistent myself, because I'm so hungry to move on to that next step that you just have to take your time and dose your plan of care appropriately. Having this person come in 3 times a week is probably a waste of their visits and their benefits, because a lot of this stuff they can do on their own at home. So you can utilize telehealth to check in with them and go over some of these things. I actually think that's a nice resource, because you can start to tweak how they can use a mirror at home, what they can use to actually work at home. So be careful not to gas out all of their visits when you're doing this approach. But if you want more resources, the Graded Motor Imagery Handbook is outstanding. It's probably the best place to get the most in-depth knowledge and descriptions on it. And I suggest it for anybody who's working with anybody in pain, which is probably everybody listening. And then I was able to publish recently a case study on the clinical application, very similar to the Sawyer study, but in someone who had complex regional pain syndrome of the foot. Again, even though it's a different body part, the process is pretty similar. And so with that case study, it's very detailed. So if you want some of the steps and the clinical reasoning about why I moved to one step or the other, it's a nice case report to do that along with the Sawyer.
Awesome. So you can see there's so much above modalities, right? That this is this gap that I think is in that STAR paper that we can intervene in a lot of ways too with exercise. And so contralateral limb training is one of my favorite exercise interventions when somebody is really unable to tolerate exercise specifically at that shoulder. And so obviously we're all familiar with this crossover effect that we get as far as strength gains go, that when we train, so in this case, let's say that her left shoulder is the affected shoulder. That's the shoulder that we're treating, but she's unable to tolerate because of high irritability. We're just going to do, basic whatever resistance exercises with the right shoulder. It shows her what we're going to end up doing with the left shoulder. So she learns the movements, learns the exercises that we might utilize, but we also get that potential crossover strengthening effect, which you can see maybe greatest when we use some type of eccentric training, eccentric loading, getting more strength, cross-education strength on the other side. Distal considerations as well, I think, is really an important variable. So just because their shoulder can't tolerate a lot of load doesn't mean I can't focus on grip training. And there's a correlation between grip strength and rotator cuff strength. So the stronger we can get your grip, potentially that may have a beneficial effect on shoulder strength as well. And then the idea of total arm strength. So forearm strength, wrist extensor strength, bicep and tricep strength, elbow flexion and extension strength can all have a positive impact on overall upper extremity function, which is a great thing to do from an exercise perspective when we're in that high irritability phase.
So, as we are thinking about those individuals with high irritability, a lot of times we need to be thinking about this whole regional interdependence approach. So we talked about graded motor imagery, which really dials in on the central nervous system changes that happen when someone's in pain. Eric's gone on to say, hey, we can look distally or contralaterally to start to get some movement and maybe some physical movement going. But what about the cervical or thoracic region from a manual therapy or even exercise perspective? And obviously, there's a lot of upcoming research on this that we've seen for the past 10 years. Paul Minkin's work on looking at thrust of the thoracic spine. Obviously, the clinical prediction rule did not validate, but we still see that there's benefit for some individuals, and utilizing a test, treat, retest approach, we can see, did what we did at the thoracic spine or cervical spine make a difference? And we can see from some of the literature shown here that there is some evidence that supports the use of looking particularly at both the cervical thoracic region and really the cervical spine being an area of growth for me where I probably didn't look at it enough. And when you start to look particularly at that lower cervical spine, CT junction, C5, C6 are really hot spots, getting on those areas, mobilizing them, and then seeing, is there a relationship between their shoulder and their neck pain? And typically what I find when you're going through your patient interview is when you start to ask about, other areas on their body chart or their body regions, if you ask about neck pain, a lot of folks will say, after my shoulder's been bothering me, it's been super sensitive, my neck and my shoulder right over in this area are pretty sensitive. And so, a lot of times you'll start to see that, yeah, they actually have neck pain along with this. And you start to ask questions, you can start to see there's a relationship there. So start adding that into your hypotheses from the get-go and asking patients who are coming in with shoulder pain, whether they're irritable or not. We should be looking at these regions and seeing if there's any, validity in working into that. So let's next slide there, Eric, and then I'll kind of like to show this. This is an interesting study by Richard Rosedale, where they looked at, what's the prevalence of maybe the spine playing into folks who come in with extremity pain. Now, I know there's been some critiques of this, and can we really say that there's a spinal source for some of the pain going on? But nonetheless, I think it's interesting to look at these individuals took a MDT approach, but when they targeted looking at the spine or moving the spine, they found that there was at least some correlation in these areas. And if you look at the shoulder, you can see that there was quite a bit of individuals who had some spinal contributing or relationship going on. And you should see that pretty much the more proximal that region or joint is to the spine, there's more of that interrelationship, at least from this data. So I think it's important to look, out of this, you're looking at a pretty high probability that there may be something going on in the cervical spine. So if you're not looking at the cervical spine and pretty much all your shoulder patients at some point during your plan of care, you may be missing out on some really important features. One question that comes up a lot, when it comes to actually doing some treatment of the thoracic spine in particular is, well, if I really want to do a thrust to the thoracic spine, how can I do that in a patient who has a painful shoulder? And so I really like utilizing seated techniques because they're quick and efficient to do retesting after the technique to see its value, if it's there or not. And what I will typically do is have the patient keep their symptomatic side down and using a seated technique, get a towel to put in between their sternum and their arm to provide that slack, and putting their hand over the shoulder gives them a little bit of that tactile, kind of stability, if you will, so that they feel protected. And you can go in and do some of the mid-thoracic or even upper thoracic seated thrust techniques that I think can be really helpful in these individuals that are coming after rotator cuff repair, who are having neck pain and shoulder stiffness, and also those frozen shoulder individuals.
So then looking at specifically the glenohumeral joint, there are a number of techniques that obviously, you know, we've all been using for years and when we treat this stiff and painful shoulder. And I think a lot of these can apply in the high irritability case, but what we're going to do now is kind of take you through some progressions, and especially as people get into the moderate or low levels of irritability, what are some different techniques we can utilize? This is one of my favorite ones. And even in the case of the high irritability shoulder, I still think this can be very effective, you know, if it's used gently. But basically, Andrea Johnson, this is 2007. They actually won the Rose Award for this study. You know, for me, this was the first time that somebody was like, the concave convex rule is probably not where it's at, right? We probably have other options. And so this is more like capsular bag theory, the idea that the whole capsule gets tight, and whether you push it anterior, posterior, you're pushing it against the restriction. And so what they did is they bring them out to about 90 degrees, that you can see in the picture there. So you bring the shoulder up into some elevation, externally rotate them to tolerance, and then distract. So in that picture, my right hand is actually providing a distraction movement, pulling that humerus away from the glenoid. And then the other hand is obviously providing the posterior glide. Now in that Johnson study, they held that position for about a minute. So they dosed it in 1 minute increments, at least 1 minute increments, for a total of 15 minutes. So I think that's a pretty large dose of manual therapy, 15 minutes straight, you know, of holding posterior glides for a sustained period of time like that. They didn't oscillate in that study, but I think oscillations in that position can be very effective. That's something that I've used quite a bit as well. But the group that did the posterior glide, it's only 20 subjects. This is a small study, but that group had about a 31-degree improvement in external rotation mobility when they retested them after a number of weeks, versus the group that got the anterior glide. They compared that to the other half of the cohort that got the anterior glide, only had a 3-degree improvement. So it's kind of a neat study. And then Gutierrez Espinoza, they also looked at the exact same technique. This is the same, get them up to 90, pull and distract, and then provide that posterior glide with the opposite hand. Same technique, but saw actually about a 46-degree improvement in mobility in that group compared to about a 15-degree improvement in just a general PT group. So the general PT group just got some basic exercises and modalities. But you can see these techniques, when we look across the board, the literature, these techniques, when you compare them to no manual technique, there is a significant difference fairly consistently in mobility improvements as well as pain reduction. The other one that I haven't seen come across in the literature is this sort of leverage distraction technique where the patient is supine. You can do it seated as well, but have them in supine, put a towel around my hand. So my left hand in the picture there has a towel around it. That's going to be the fulcrum. And then my right hand, or my manipulating hand, if you will, that hand's going to provide an inferior glide and then concomitantly adduct the humerus. So you think of like pulling down and then adducting against a fulcrum like that, you're kind of getting a fulcrum type of distraction, pulling that humeral head away from the glenoid like that. So that's a pretty aggressive technique. But certainly in these moderate and low levels of irritability cases, that's a nice one when you still have some stiffness that needs to be resolved. And then I've seen a lot of different terminology used. Angular mobilization, mobilization with movement would certainly be an appropriate term. But reverse distraction is what some people use the term. You see the Argwall paper, they call it reverse distraction. But the bottom line is getting them up into that level of restriction of elevation and then concomitantly providing some type of an inferior posterior, or even type of distraction type of movement while they do that. So we've got one case report on it, and then the Argwall looked at these types of techniques, these concomitant rolling sort of manipulation with movement type techniques, and compared them to just a traditional Kaltenborn sort of APPA glide, and saw about a 25-degree improvement in elevation compared to the group that got the Kaltenborn glide. So not a ton of evidence, not big sample sizes. These aren't, you know, the most rigorous studies that we have, but there is some literature to suggest that these glenohumeral techniques in the right patient population can be effective. Interesting enough, when you look at all these studies across the board, and there are more than just these few that I've cited here, rarely is shoulder irritability a classification thing or an inclusion criteria variable that's utilized. So you got to wonder kind of if we could start fitting techniques to levels of irritability and specific impairments, you know, we might even see better outcomes in the literature in the future. I did one video for you here, and this is, I apologize for the home nature. This is during COVID with no clinic to go to, but I'm a big fan of prone techniques. When I put them in prone, they are naturally already in this position of relaxation. The arm can kind of dangle down. If they have 90 degrees of elevation, I don't have to pick them up. So I find even in high irritability cases, they're going to guard a lot less because they're already in this position of relaxation. And so much can be done there, whether it's just basic oscillatory glides where you're sort of gripping the whole humerus with both hands and gliding in that sort of oscillatory rhythmic fashion, both AP and PA, distracting. In this case now I'm inferior gliding, inferior anterior gliding while I'm holding them in a position of elevation. But you can even take that all up into having them actively or even passively bring that arm up into flexion and mob them in an inferior anterior direction in prone. So especially for anterior directed glides, prone is really nice. You can use your leverage to kind of get on it like that. And then, of course, the Mulligan coined active flexion mobilization with movement, where they are actively bringing that shoulder up into flexion while we are stabilizing the scapula and using a belt to sort of pull them back into a posterior glide there. We're running a little low on time, so we're going to move fast through the end here. They will, once you clear up the stiffness, they still tend to compensate. They will get that shoulder hike. So this gentleman had a AC joint repair. So this is post-operative stiffness. He at this point is like 15, 16 weeks out and still hiking quite a bit. And so a little note, I think, is that once you restore the mobility, the hike should go away. A great way to facilitate that is side-lying elevation. So put him in side-lying, have him elevate, and now we don't have that against gravity upper trapezius sort of shoulder hike that we oftentimes see in a seated or standing position. So that's a nice follow-up movement. Then, of course, you can always add canes and assisted type of movements with pulleys. I mean, I know pulleys are a very popular thing for a lot of people, but when we work elevation with some type of assistance, that's a wonderful adjunct there. A couple exercises for strengthening and things that we can do to really try to start waking everything up and getting them strong again. Periscapular work, PNF periscapular work. We're working isometrically in different positions and different planes of the scapula, working retraction and depression and adding resistance manually with our hands. We can couple that with loaded external rotation. So in this case, it's an isometric external rotation with a weight. And then we're adding that manual resistance, that PNF kind of scapula resistance for motor control training of the periscapular musculature. Obviously, you got your basic cable column type of work. I think that's important because resistance bands are really loading us at end range only. We like that mid-range strength. We like that early range strength. And so using cable columns and dumbbells provide us with that. I've gotten, I don't know if it's just more efficient or lazy as I've gotten older, but I don't want to tie anything to any, I don't use a ton of bands anyway, but if I am going to use a band, I don't want to create barriers and have them tie it to a door or anything like that. Just grab both hands on the band and just external rotate it. Now I get bilateral cuff training, periscapular training, I get all the central benefits of exercise. It's a really nice all around sort of shoulder girdle movement as opposed to just unilateral resistance band training. And then the last one here, again, a bilateral resistance band movement, but working it in supine, and then I can add resistance and add perturbation and see if he can control it different angles of elevation. So as he progresses his angle of elevation mobility, we can add load through that. And then I think don't forget about the upper trap at the end range. So working upper trap in elevation, because you really do need that shoulder hike to get your arm up overhead and to reach up into overhead shelves and stuff like that, taking a suitcase out of an overhead compartment, an airplane, something like that. Low, light weight, but working that kind of punch up towards the ceiling type of movement is a really nice end stage exercise to get that going. All right, now we are going to address your questions in the chat. Thank you, everybody, so much. Take care.
Thank you.